laryngectomy, and I have chosen this supracricoid laryngectomy because that happens to be the common one, open partial laryngectomy, which we perform. So, a brief introduction. In open partial laryngectomy, we excise the whole specimen with a margin in an end block containing the mucosal layer, membranous layer, some mucosal space, muscle, and corresponding cartilage. So traditionally, we have this classification depending upon the horizontal or vertical. That is, for glottic, we have laryngofissure and cordectomy, vertical partial laryngectomy, supracricoid laryngectomy, and for supraglottic, we have horizontal supraglottic partial laryngectomy and extended horizontal partial laryngectomy. But the recent nomenclature we have is from the European Laryngological Society, which divides them into type 1, 2, and 3, depending upon where we give the cuts horizontally, either above the cord, below the cord, or below the cricoid cartilage. That is horizontal supracricoid and supratracheal laryngectomy. And we also put the suffix A and B upon whether we preserve the suprahyoid epiglottis or we remove it. There are various extensions to it, whether we remove one partial arytenoid or complete, or we remove part of the base of tongue or piriform sinus. So typical of OPHL1 is we give the cuts above the glottis, and we remove and block, removing the whole of the pre-epiglottic space, including but preserving the hyoid, but removing the epiglottis too. And the OPHL 2A and 2B, depending upon we preserve the epiglottis or remove the epiglottis when we remove the tumor. And 3 is above the trachea. So there are various indications. Mainly, there are tumor factors. These are mainly done for intermediate size tumor, T2, T3, and T4A, and which are mainly preferred for those tumors which are anterior in the larynx. That is, we divide the larynx into anterior and the posterior paraglottic space at the level of the arytenoid, tip of the arytenoid, vocal process of the arytenoid. And the patient factors is they should have a good performance status. They should be able to climb 2 flights of stairs or good pulmonary reserve. Age is not a contraindication, but we prefer to do it less than 70 years of age. So the contraindication being if there is a major pre-epiglottic space involvement or posterior commissure involvement, both the arytenoid cartilage are involved, extensive extralaryngeal spirit lesion which is reaching out to the first tracheal ring, or if it is involving the base of tongue or piriform sinus. In salvage surgery, the indications are in the recurrent cases T1, T2, T3, and contraindications are if the arytenoid is fixed, if it is involving the valvula, base of tongue, pre-epiglottic space, or significant subglottic involvement, that is 10 millimeter anteriorly and 5 millimeter posteriorly, extensive tracheal invasion, posterior or inferior paraglottic space invasion, or extralaryngeal space through cricothyroid membrane. So if you see in the literature, in the OPHL for primary, they are mainly done for T1 to T2, T3, and some of T4A, and we can get a good 5 years local control ranging from 70 to 90%. And for the salvage cases, it's mainly done for T1 to T3, but rarely for T4. And they also have a good local control ranging from 70 to 90%. So I would like to ask from the expert opinion, any one of us can say what are the indications for open partial laryngectomy in their institute. So Dr. Sivaraman, you can let us know what is your preferred open partial laryngectomy indication and the preferred one in your institute.
Actually, with the advent of novel radiotherapy techniques and the narrow field, in a primary setting, it has come down very much. Why? Because in a primary setting, if it's a T3 larynx, if we do a supracricoid laryngectomy, partial laryngectomy, we need to augment that with adjuvant radiotherapy. So the functional outcomes are still better with straight away going for chemoradiation, especially the advanced. So in a In a salvage setting, yes, for T1 being T1 even after radiation therapy or T3 larynx, limited T3 larynx, still have a role for open partial laryngectomy, especially when there is preservation of a speaking, breathing, and swallowing organ. So we have done very limited salvage setting also. I have done at least just only one supracricoid partial laryngectomy. The other one I wouldn't even count because we salvaged it with the total laryngectomy later. So if the post-op, with the post-radiation cases are not involving the pre-epiglottic space, even if it involves a pre-epiglottic space, we can do. But I would prefer pre-epiglottic space is not involved in limited paraglottic space, and at least both arytenoids being while I would prefer. But the classical indications are given in the textbook. At least one arytenoid unit is enough for a partial laryngectomy. And the patient's functional status should be good, and the age should be also be a criterion. And we also do a lot of laser in these cases. Sometimes if it's just a T1 disease or a T2 disease amenable to laser, we go for transoral laser excision.
Right. Any other difference of opinion from other panelists? Dr. Kannan, Dr. Divya, Dr. Hers?
Hi, Dr. Amit.
Hi.
So I think whatever points you've already pointed out and what Dr. Shivaram just pointed out would stick to the same. In fact, even in our institute, we haven't done, to be very honest, we haven't done any open partial steps or procedures as of yet. Uh, Frankly, because of the either the case selection, we were not sure that this would be a good case, or because of the pulmonary reserve. Majority of the advanced laryngeal cancers that we do see end up with age in the age group bracket of more than 65 to 70 years, and with pre-existing COPD. So those cases, anyways, having a poor pulmonary reserve, you wouldn't want to select those for an open partial. So I believe, apart from the tumor characteristics, one of the most important things I would be looking for is subglottic extension, number one, and of course the presence of a functioning cricoarachnoid unit, and even beyond that, the pulmonary status and the reserve of the patient. So I think these three things are really very important. And just a point, an interesting point to add. A lot of papers looking at chemoradiation in the last 2 decades, and there is even an I think there's a paper by Higgins et al. Which actually showed that with the evolution of chemoradiation, there is actually a significant amount of patients who actually end up with having a salvage laryngectomy. So maybe slowly the hypothesis might change that for select T2, T3 patients, we might opt for an open partial laryngectomy upfront rather than referring for a chemoradiation. So I think those factors need to be identified. For example, vocal cord fixation, extensive paraglottic space involvement, and a bit of a posteriorly based disease. I think these three factors should be looked at, and we need to compare our results of chemoradiation vis-a-vis the presence of these factors, probably to better select those patients who might do better with an open partial upfront rather than being sent for chemoradiation.
Okay, right. But what in the salvage setting, if, for example, if there is a T1, T2 lesions, and after radiation there is a recurrent disease or a residual disease, so still we means what is the opinion about the laser versus open partial laryngectomy?
So any T1 disease, even in a post-radiation setting, if the paraglottic space is all free, we would go for laser laryngectomy. If there is difficult suspension, we cannot reach the tumor on when we do a direct laryngoscopy to assess the feasibility of laser. If it is not feasible, T1 stroke T2 disease can go for open partial laryngectomy. In our center, we would usually do vertical partial laryngectomy only when laser non-suspendable T1, T2 larynx. post-radiation. Per primum, we usually don't do conservative partial laryngectomy surgeries. So these numbers, as Harsh told, will be very few, probably in 10 years, 3, 4 cases. But open partial laryngectomy, when laser non-suspendable, T1, T2, before radiotherapy also, and recurrence.
Okay, this is an important point. Yes.
Yes, I do agree with Dr. Kannan and Harsh there. The most important factor here we have to look into is a pulmonary status, and most of these patients will be smokers. So when you consider open partial laryngectomy in all these patients, the most important factor we have to look is into the pulmonary function and any risk of aspiration in these patients. So if there is any micro aspiration prior to open partial laryngectomy, that has to be picked up, because after the procedure, the chance for decannulation and the outcome of the surgery will be affected by the aspiration problems. So prior advocating an open partial laryngectomy, we have to evaluate the swallowing of these patients, and we have to exclude any aspirations in this patient prior to the surgery. So with the advent of this laser surgery and the recent modalities of radiation, new technologies, open partial laryngectomy as primary surgery is coming down because of these factors.
Okay, so is there any specific way to evaluate this?
That is usually by the clinical evaluation and also by the FEES, fiber optic evaluation of swallowing, and we can also go for a video fluoroscopy to look for microaspiration.
So there are 2 points which are coming out. One is that if we cannot expose, then we can go for open partial. But our data in our institute shows that our salvage with a CO2 laser, the result is not that great as an open partial, because if you compare the primary with the salvage cases in our institute, what we get is we can get only half the result of what we get in the primary cases. And even the laryngectomy-free survival drops down very much to around 20% in this salvage cases.
Yes.
So laser is for the salvage cases, we are not yet preferring very much because of this poor result. And we tend to go for open partial laryngectomy exclusively for salvage cases. So that is one point which we follow here. Maybe the result in other center may be a bit different.
So Dr. Amit, to get it clear, even for a T1 larynx which has recurred, mid-cord you would go for open. You would prefer to go for open and laser.
Open, yeah, because most of the time the laser with the after RT we actually don't know what is the actual margin of that tumor. So the tissue planes are not that good in the post-RT cases. So we prefer to do mainly the open partial in salvage cases.
Agreed.
But Dr. Amit, if it's a upfront setting, I mean, before radiation itself, if it was a T1 to begin with, and even in the
T1, T2 here also is the same thing. So we practice primary non-surgical modality. For T1, mid-caudal we may go for laser, but the remaining we go for this radiation therapy, and supraglottis also is radiation therapy. So it's
there is one study when they had compared the histological characters with the primary and the salvage, the multifocality, the chance of perineural infiltration, involvement of the cricot, they are all high with the recurrent lesion, even though the mucosal disease is small. So to get a margin clear resection in a recurrent disease, even so, what I completely agree with Amit sir in the laser surgery in the salvage setting. If it is not a mid-cord lesion, a little more higher disease, these all factors has to be kept in mind because of the high chance of multifocality of the disease and tumor dissociation. So they have very well studied this and they come up with these factors comparing the primary and the radio-recurrent diseases. So when we address the issue, these all factors has to be kept in mind before going for a surgery in all these patients.
Even I agree. I have a point to make. In laser, it is difficult, as Dr. Amit sir clearly told. It's very difficult to get the margins. Though the advantages slightly stand up because we are not cutting the staph muscles in laser. So the aspiration chances are little less with laser. But the quite challenges Amit sir told very clearly, getting a deeper margin. But that's why they are advocating multi-block resection. We have to do till the margins are negative. And there are reports. I mean, these are not, as Harsh pointed out, there are no multi. Experience with laser is not that good in LSA.
Okay, right. So that is just to bring out the point about the primary versus the salvage setting in for the open partial laryngectomy. But for primary, obviously, if there is exposure is not good, and some tumor like adenocystic carcinoma, where upfront RTs will not be a right choice. So in those cases, we prefer to do surgery first, either laser or open partial. So we'll come to the steps. So the aim of this surgery will be, we want to remove the tumor end block with adequate margin while preserving the function. That is, we all have discussed, that is, we want to make the patient breathe without tracheostomy, and they can swallow without aspiration, and they can have some voice, though it may be hoarse. So what we'll discuss is, we'll discuss how to remove these tumors in and with margin, and in certain steps, what are the potential complications we can have, and what can we do in operative techniques to prevent these complications. So it's like typical patient. This is a 69-year-old patient with T1CA larynx, which was treated with radiation, 60 degrees for 3.5 weeks. He has got a disease-free interval of 5 months. And in a follow-up FOL, there is a right true cord lesion. And imaging, we get a MRI, we get a suspicious node plaque in the right true vocal cord. Biopsy has shown as a moderately differentiated squamous cell carcinoma. And PET shows a mild diffuse uptake in the right true vocal cord. And there is no other uptake elsewhere in the body. So what is the how do you evaluate such cases in your routine practice when the patient comes with a follow-up with FOL, there's a lesion? So what are the aims of how we want to map the tumors, or how we want to check the functionality of the larynx? So we can, any one of the panelists can pick up this and this.
So first, as you did, we'll do an imaging, and then we'll do a fiber optic scopy in the OP to check for the vocal cord mobility and cross involvement. All these patients would be subjected for a direct laryngoscopy and assessment. So we would look for the involvement of the posterior end of the tumor. So how far it is from the vocal nodule, anterior end of the tumor, whether the ventricle is involved or not, and whether it is suspendable, whether the anterior commissure is visible. If all these things are feasible and the paraglottis appears free in your as per imaging, I would prefer a laser if feasible. If it is not feasible, if it is not suspendable, this patient would go for a vertical partial laryngectomy.
Okay. Is that okay with other panelists, or they have a difference of opinion?
Absolutely. So,
Tuberculosis patients also.
So scopy is important and imaging is important to map the disease, because some of the scopies from the FOL we can
Tuberculosis patients
deeper
also.
extent of the tumor, that is lower
Tuberculosis also
extent
have.
in OPD setting. So they may require evaluation under general anesthesia.
So one
regarding the points of, yes, ma'am, please go ahead.
One more point here is one, we have to check the previous disease status also. The first disease, where it was, what was it exactly. This is post-RT patient, the previous, the primary disease.
Primary disease was also in the same true right vocal cord.
Vocal cord.
Mm-hmm.
Yes, sir.
So
the map out the disease.
Yeah.
Exactly, sir. That's the same point which I had. We will have to go through the previous disease. What was the status? How much extent was the disease? We have to go through the whole details again, and we have to check it with we have to go through the previous details. That is what I have to add here also.
So that is an important point because we have to know whether it's a disease is coming from the same side or it's from the
Exactly.
other side.
Exactly, sir.
So that is a okay.
Regarding the choice of imaging, would you always do a combination of a MRI with a PET, or in this particular case, you supplemented also with an MRI? Or just wanted to know your institutional protocol, Dr. Amit.
Any recurrent cases, we prefer to do a PET to see,
Right.
and for the disease extent, we would like to do an MR because we want to know the paraglottic involvement, though we can get it in the CT also, but the MR we feel is a bit better to see for the paraglottic.
Yes, I agree. And sometimes even to differentiate between post-radiation edema and disease recurrence, sometimes a PET is not able to give us that specificity. So many cases we supplement with a screening MRI with DWI imaging that with the DWI sequences helps as a problem solving tool in such cases.
Same.
Yes.
So we can come to the proper steps now. So incision, we give a horizontal incision, crease incision, that is at the level of the cricothyroid area. And maybe if we are planning for neck dissection, we may give a capillary and extend a bit up. So that is a standard incision. And the subplatysmal flap we have to elevate, and we go up to the hyoid bone, slightly above the hyoid bone, because we need to put a suture there at the end of the surgery. So the exposure of the area is important, and like at the anterior jugular, because we need to release the strap muscles. So the strap muscles are released from the superior end after dividing in the midline, like we do for the thyroidectomy. So the sternohyoid is released from the hyoid, sternothyroid from the thyroid, and the thyrohyoid also is released from the hyoid. And the strap muscles are retracted laterally after releasing it, so that the whole larynx can be exposed. So it's just releasing the sternothyroid on the opposite side, and this is the sternothyroid. The thyrohyoid, sorry. So, and it's reflected laterally. And we need to scrutinize the larynx. So first we have divided the thyroid isthmus. And like we do for the total laryngectomy, the inferior constrictor has been released, and the periosteal incision has been made, and the PFS mucosa is retracted medially. So elevation of the PFS mucosa. And the inferior cone can be cut here so that we can protect the recurrent laryngeal. That is important because we need the arytenoid to be functional. The phonation is going to occur by the arytenoid mucosa now. So posterior release of the strap muscle and elevation of the PFS mucosa, is there any specific point we want to do practice here so that we prevent certain complications? So,
I think regarding the elevation of the PFS mucosa, in case we are having kind of a marginal zone tumor or tumor spreading slightly into the piriform on one side, and probably on that particular side, we want to be careful as to how much mucosa we are elevating off, or whether we want to take a little bit of margin on the pharyngeal mucosa or not. So that is one thing that needs to be kept in point. But otherwise, normally we would elevate the mucosa almost up till the midline.
so
Amit,
that is what we practice for the laryngectomy. But this tumor with the open partial laryngectomy for the supracricoid, we would prefer to do in those cases which are purely endolarynx and which are anterior place. That is anterior to the vocal process of the arytenoid.
Yes.
Dr. Amit,
Yes.
Is this the same patient you showed us, the mid-cord lesion?
Yeah.
Why not we do a vertical partial vertical partial right side, go in straight. You preserve the outer perichondrium, preserve the straps, disconnect the sternothyroid and thyrohyoid.
That is also an option, but the practice we can also do the vertical partial laryngectomy in this situation, but supracortical laryngectomy is also an option for this because the functional functionality as more or less is going to be the same.
Okay.
And what is do we preserve the internal branch of the superior laryngeal nerve? Because we have been taught that the internal branch of the superior laryngeal nerve supplies the mucosa above the vocal cord, so it may help in the swallowing process. So preservation of the internal branch of superior should be even do these steps in this surgery. So
whenever, particularly in endolarynx, preservation of the superior laryngeal internal branch of superior laryngeal nerve is critical. It decreases the aspiration and post-operative complications are much lesser.
right.
Definitely decreases the chance of aspiration.